Tekrar hoş geldiniz.
Welcome again. I will be talking about high-risk groups in children with sleep disorders. Let me start with the definition of sleep. Sleep is a naturally repetitive process in all living organisms. It makes sure that organism is restored. There is loss of consciousness or there is reduction in consciousness, and there is relaxation on all muscles, and almost 1/3 of the lifetime is spent in sleep. You see the classification of sleep disorders in children in DSM, and I am going to walk you through this classification. The development of a sleep order happens during breastfeeding, and apnea or some other syndromes can be seen at this age.
6 ayda gerçekleşiyor.
The sleep develops in the first 6 months. As you see here, the sleep order might be different, and an infant might sleep even 18 hours, but after 6 months it comes to average figures, and then it goes down, and around the age of 5 it's almost 11 hours. Waking up during the night, this incidence is high, especially in the first year of life, but after that the sleep order is constituted. There are 2 rhythms, ultradian and circadian rhythms. Ultradian rhythm is a shorter rhythm that goes along with NREM and REM cycles, and circadian rhythm is a 24-hour rhythm. Sleep, awakeness, the body temperature, hormones all play all affect the circadian rhythm. Ultradian rhythm is different at different ages. For instance, it is post-conceptional under the age of 34 weeks. It's not periodical, and in babies between 34 to 36 weeks, it is 35 to 45 minute cycles, and when the child becomes an infant, it's almost 50 minutes. In the newborns, sleep starts directly from the REM stage, and after the first 3 months it is quiet in the beginning of the sleep, and REM comes later. In the first 2 months there is an equal distribution of non-REM and REM, and after that sleep starts with REM stage, and towards the end of the night there is REM. Kleitman studied the sleep cycle of children. Within the box you see the awakeness. As you see, after a certain period of time, after 15 months or so, the awakeness is longer, but before that children might sleep at different hours of the day. When we look at the circadian rhythm, we see that when the baby is term, there is randomness in sleep or awakeness, and at the first month the body temperature starts to function in a circadian rhythm, and at 3 months hormones actually derive the circadian rhythm, and sleep consolidation happens between 3 to 6 months. There are biological and cultural markers of sleep. Homeostasis and circadian factors are biological markers. Parents' behavior and social norms are cultural markers, and these markers vary from country to country or city to city. Sleep order, sleeping time, the objects used to sleep, daytime sleep, sleep problems are all changes in sleep attitude. For instance, the child wearing his pajamas, brushing his teeth, playing with a toy, or reading a book to children are some examples. When we talk about high-risk groups in children, we see that the biggest group is the group in which there are children who have inadequate sleep. It's 10%, and this is higher in adolescents. It's 33%. 2 to 3% of children have respiratory disorders in sleep. However, since the rate of diagnosis is lower than the actual case, maybe this rate is higher. Narcolepsy, parasomnia, and rhythmic movement disorders are some other problems. Risk factors that cause inadequate sleep are atopic dermatitis, asthma, epilepsy, attention deficit disorder. Attention deficit disorder concerns the audience here, therefore I would like to elaborate attention deficit disorder in relation to sleep disorders. Attention deficit disorder should be evaluated together with restless leg or sleep disorders, and children with attention deficit disorder should be evaluated in detail in terms of sleep disorders, and we have to pay attention to children especially who have resistance to treatment. Autism, anxiety, depression, girls, and the consumption of alcohol and caffeine, they all are risk factors for inadequate sleep. What is the total sleep duration in children? You see that in the first month there is a diversity. However, at the age of 1, you see that the distribution is almost the same. I mean, at the age of 1, the child sleeps maximum 11 hours. Before that, it's 16 to 17 hours. And a child of 16 years of age sleeps 8 to 7 hours or 11 to 12 hours. So there is a huge difference between the first months of life and later on. And everyone has a different sleep cycle. When the baby is a newborn, is an infant, the sleep normally restricts itself. However, when the baby grows up, becomes a child, you see that they wake up during the night, and there is night terror, and some fear and rhythmic movements can also be observed, and resist at school age is another problem. And in adolescence, delayed sleep phase is observed, and the adolescents go to bed very late and wake up very late. When we look at insomnia, we see that there are 2 types of insomnia. There is resistance to sleep, the difficulty in sleeping, and also Another type of insomnia is where the child cannot continue sleeping, cannot sleep alone. And anxiety, performance loss are some consequences of this insomnia. History is very important in insomnia. The problem should be described clearly. We have to pay attention to the relationship between the parent and the child, and we have to evaluate the ordinary life of the child. We should not focus on some special occasions like going to another city, staying with friends, etc. And this should be a 24-hour evaluation. The daytime sleep should also be evaluated. Childhood behavioral insomnia is a difficulty in going to sleep, and because of the environmental conditions, the child might have difficulty in falling asleep. And respiratory disorders in sleep is another risk factor, is another problem, and the risk factors for this problem is actually problems in the upper respiratory tract and muscles, adenotonsillar hypertrophy, craniofacial abnormalities, neurological disorders might be some risk factors. The respiratory problems in sleep can be characterized with primary snoring, and then there is the upper airway resistance syndrome and also obstructive sleep apnea, which is the biggest problem for pediatricians. And there is a loss in airflow and also an impairment of the gas exchange, and this causes sleep apnea. Primary snoring is caused by some narrowing in the upper airways. However, it's not possible to diagnose the condition by clinical signs only. PSG is necessary. We don't know the clinical consequences. We don't know whether we have to follow up this condition for a long time. This is an unknown thing. And obstructive hypoventilation syndrome is a partial obstruction in the airways, and apnea can be observed in this case. The upper airway resistance syndrome is difficult to diagnose because this can be diagnosed by pressure monitorization, and there are not many centers in the world doing that, but some other signs can give us direction. There is sleep fragmentation, snoring, and limitation on nasal pressure, and there is increased arousal, and the gas exchange is normal. This is a polysomnography of a patient with this syndrome. There is no esophageal pressure monitorization, and you see the limitation on nasal pressure. Normally this should be a flat line, but you see that it goes up and then makes a plateau and goes down. And here you see paradox respiration, the paradoxical respiration at the abdomen and chest. Obstructive sleep apnea is the most difficult and the most important and common problem in children. This is a problem that we need to resolve because the complications and morbidity is caused by obstructive sleep apnea might be irreversible. Partial upper airway obstruction and or intermittent full airway obstruction causes disorders in sleep pattern in obstructive sleep apnea, and the epidemiology shows that probably the rates are higher. It is said that the incidence is 1 to 3% before school, and 20% is intermittent when it comes to snoring, and 7 to 10% continuous snoring, and obstructive sleep apnea is common in children between the ages of 2 to 5. When we look at sleep, we see that before before falling to sleep, there is an increase in the upper airway resistance, and there is a relaxation of pharyngeal muscles, and then you see hypercapnia. Physiological consequences of obstructive sleep apnea, one of them is intermittent hypoxemia, and this causes pulmonary artery pressure increase and cor pulmonale at the terminal stage. But more importantly, this might cause some cognitive and behavioral disorders which might be irreversible. And because of fragmentation, sympathetic activation is observed, and neural tissues, brain and vasomotor activity might be altered because of this problem. When we say obstructive sleep apnea syndrome, we're not talking about a single factor disease. I mean, it's a multifactorial disease. Adenotonsillar hypertrophy, microglossia, obesity, reduction in muscle tone, etc. I mean, different factors are at play in this disease. And what are the symptoms? Night and day symptoms. Night symptoms are snoring, apnea, restless sleep, waking up frequently, sweating, and enuresis. And during the day, you can see irritability, aggressive behavior, decrease in school success, loss of appetite, or sleepiness during the day. Intermittent hypoxia, inflammation, and sleep fragmentation all lead to respiratory disorders in sleep, and then this causes metabolic cardiovascular consequences. For instance, when it comes to metabolic consequences, there is impairment of glucose metabolism, and together with that, a sympathetic system is activated and some hormonal changes occur. For instance, this might lead to changes in eating habits and consumption of high energy food, and hypertension might also be developed, and these all together with impairment in glucose tolerance might result in weight gain or obesity. Obstructive sleep apnea and obesity, since they go hand in hand, this makes us think that they have similar processes and they interact with one another through inflammatory processes, and they are both systemic inflammatory diseases. Here you see sleep duration in obese children. These are obese children. Sleep duration in obese children when compared with controls is quite lower. However, in children with high weight, there is a decrease in sleep duration. So in this inflammatory process, there is first an increase in sleep duration, which is a compensation, and then together with eating habit changes, there is a reduction in sleep duration. Obstructive sleep apnea might have an impact on cardiovascular system because endothelial dysfunction might be the final result, and this has been studied at length in sleep apnea. Sleep apnea also might impair the neurocognitive functions, intelligence, memory, academic performance, analysis abilities might be impaired by sleep apnea. I talked about endothelial dysfunction. Oxidative distress and inflammation lead to endothelial dysfunction, and it might also lead to cognitive dysfunction, and so these two processes go hand in hand. How do we measure endothelial dysfunction? You see peripheral artery tonometer used here, and on one arm a systemic pressure is applied, and 1 minute occlusion is measured, and hyperemia after this 1 minute pressure is measured for 30 seconds, and neurocognitive tests are also given to these children to see whether there are neurocognitive dysfunction. Memory is affected by obstructive sleep apnea, especially memory task acquisition and retention is impacted. 26 animal pictures were shown to children for 4 times before falling asleep, and then the animals were asked to these children, and finally 10 minutes later these pictures are shown again, and they're asked about these animals, and also they're asked about these animals in the morning. The black ones are children with apnea, and these children show that they have a worse memory, and it's more difficult for them to remember the names of the animals. And then we are confronted with a phenotype of obstructive sleep apnea. Of course, prematurity, asthma, other accompanying diseases, environmental conditions, obesity also influence or affect the phenotype of the sleep apnea. Snoring is important. Snoring for more than 3 nights is important. Apnea, suffocation feeling, and also increase in attempt to breathe, waking up frequently, dry mouth. These are some signs, and we also see failure in school success, aggressiveness, hyperactivity, attention deficit, sleepiness during the day, difficulty to wake up, depression can also be observed. So these are all about the history of this syndrome. In physical examination of the neck and head is important. The face might look as adenoid. Polysomnography is the gold standard in diagnosis of obstructive sleep apnea. It identifies the level or the stage of the sleep apnea, and also is determinant in the success of the treatment, and also it makes sure that we can make a differential diagnosis. The indications are respiratory and non-respiratory. Except for the diagnosis of obstructive sleep apnea, patients who will undergo tonsillectomy because of sleep apnea should also undergo polysomnography. I talked about adenoid faces. You see long faces, and these are obese patients, and also the circumference of the neck is wide. This might also lead to obstructive sleep apnea. And as a result, the children are less successful at school. There is depression, attention deficit, hyperactivity, social phobia, and memory impairment. So these all have a significant effect on the quality of life. As a summary for obstructive sleep apnea, we have to question and investigate all children in terms of snoring. We have to be careful with high-risk patients. We have to carry on emergency procedures for cardiorespiratory deficiency, and polysomnography is the gold standard in diagnosis. The first treatment option is adenotonsillectomy, and for additional treatment we need to have a post-operative evaluation. We also have parasomnia in children, irregular sleep, inadequate sleep, epileptic seizures, obstructive sleep apnea, post-traumatic stress disorders, and nocturnal panic attack. In children with these conditions, we see parasomnia. These are unwanted events during sleep or while falling asleep, arousal disorders, REM-related parasomnia, and others parasomnia are the types of parasomnia. Non-REM arousal parasomnia can be seen in the first half of the night, and it is for a short time of period. It is very difficult to wake the child up, and there is difficulty in description, and he can go back to sleep quickly after this event, but he might also experience amnesia. He might not remember anything. Confusional arousal happens in the non-REM sleep. He doesn't recognize the parents, shouts, cries, and that child is not cannot be you cannot understand what he says. Sleep terror is common between the ages of 5 to 7. Most of them become sleepwalkers, and 50% is finalized at the age of 8. It occurs during non-REM sleep. It starts with a crying crisis or screaming. There is agitation and there is confusion. It is difficult to wake the child up, and even if he wakes up, he doesn't know what happened to him. Sleepwalking. It might be quietly wandering around, and injuries are rare in that case, and also there's agitated wandering, and the daytime behavior of such children should also be investigated. Arousal disorders require us to investigate the family as well. You see a lot of family members who are affected by this condition. Polysomnography can be performed if there are atypical attacks, and if there is a stereotype or there is aggressiveness. And sometimes you can see arousal disorders together with obstructive sleep apnea. So polysomnography is necessary for a differential diagnosis. If we look at the REM-related parasomnia, these might nightmares or sleep paralysis, and this is mostly seen in adolescents, but rarely. We can also see behavioral disorders in REM sleep. Nightmares. At least 75% of children has one nightmare, and between 10 to 50% of children, this is so high that parents are disturbed, and they mainly have nightmares between the ages of 6 to 10. They see nightmares, especially in the second half of the night. These are complex dreams. It starts like a very beautiful dream and turns into a nightmare, and the child can talk about his nightmare and can be calmed down easily. Could you please wrap up? Generally, nightmares are related with creative personalities, and post-traumatic stress disorder can be seen at a rate of 80%. Restless leg syndrome, we have to differentiate it from growth pains. There is difficulty in falling asleep, and iron deficiency should definitely be investigated in these children. In polysomnography, PLMS index is higher than 5. When you ask the child, they explain you that they have kind of a tingling in their legs, and when you ask them to draw a picture, this is one of the pictures that they draw. Enuresis can be seen, is called bedwetting of 2 or more times in children over the age of 5, and in children with enuresis, we see that the plasma vasopressin levels in these children are lower. This is one of the causes of enuresis. There is decreased bladder capacity in these children. In patients with obstructive sleep apnea, if the sleep apnea stage is higher, you see enuresis more frequently. Thank you very much, and sorry for exceeding my time.